I'm from Beijing, China, Peking University, People's Hospital. My speech is also on this disease, that is hyperhidrosis. The topic of my speech is sympathicotomy for palmar hyperhidrosis, the association between the intro-operative hand temperature change and the curative effect. Professor Tu Yanren have presented some typical cases of hyperhidrosis. I showed some other cases. This is a This is a typical hyperhidrosis patient, and sometimes we can see the water deep from the hand, and many patients combine with food sweating, and some patients combine with underarm sweating. The hand of the patient may be wet, cold, and pale. Sometimes it can also be red. As we all know, hyperhidrosis, traditionally it is not a disease of our thoracic surgeon. It is a disease of your dermatologist. But perhaps in your subject you have little can do on this disease. But we have such a operation, that is endoscopic sympathectomy surgery, as has proposed by Professor Tu. The hand, the sympathetic innervation of the hand is from the upper thoracic segment, that is from the T1 to T5 spinal cord. It originated from this segment and extending where the sympathetic chain to the hand. So it is possible to transect on certain segment of the chain to treat hyperhidrosis of the hand. So this is in the thorax, and this is to the hand. As has presented by Professor Tu, this procedure is very effective. Its effective rate near to 100%. But it have a common side effect, that is compensatory sweating. That is the sweat on the hand was treated, but the sweating on the chest, on the back, got worse. Traditionally, this procedure is resection of some or certain of the certain segments of the sympathetic chain, and it got two very severe and very common side effects of compensatory sweating. In the past 2 decades, this procedure modified once from resection to transection, and later from multiple level transection to only one level, only one side transection, and from higher level to low level, that is from T2 gradually to T3, and now T2 to T4. Now T3 sympathicotomy and T4 sympathicotomy are both accepted to be the standard method for PPH. In 2009, published the first randomized controlled trial to compare T3 and T4, and we got the result that T4 was superior because it has less compensatory hyperhidrosis, and it have the same efficiency with T3. later, on 2010, 2011, they have two similar research got the similar result. Now let's summarize T3 with T3 and T4. For T3 procedure, a patient may got good effect, or some patient may got over dry of the hand, but it has more severe or more often of side effect. That is, some patient may result in moderate compensatory hyperhidrosis, which got they were annoyed by the side effect, and some patient may regret of the procedure. Some patients only some. T4 sometimes many patients got good results, but some patients may have residual symptom. That is, his sweating got partial remission, not completely. Only some patients, and it have little side effect. So I think if the patient is a regret, we have little solution. We have no solution. But if the patient feel moist, not satisfied with the procedure, we can re-operation, I think. So that is why I recommend T4. So T4, almost no side effect, but perhaps 5 to 10% patient may got partial remission of their hand sweating. So which patient may got partial remission? And I'm puzzled about these years. So I think if it can be pre-recognized, procedure adjustment will be feasible accordingly. How can we pre-recognize? As we know, sympathetic nerve innervates the sweat and the small blood vessel in the hand simultaneously. So I think if it is possible to, I think to verify whether it is reasonable to predict the curative effect according to the intro-operative hand temperature change. So this is the purpose of our small study. We monitor the hand temperature change during operation using a non-contact thermometer. We record the temperature of the operation side hand before transection, and 1 minute, 3 minutes, 5 minutes, 7 minutes, 10 minutes, 15 minutes, 18 minutes, 20 minutes after transection of the sympathetic chain. We choose the maximal temperature change elevation as for evaluation. Yeah, this is the procedure. The patient was under general anesthesia, semi-sitting, semi-Fuller's position. This is a small incision, very similar with Professor Tu. This is the sympathetic chain on the thoracoscopy. That is in our operation. Sometimes it is very visible, and sometimes it's not so clear. This is a small incision. From July 2011 to April 2012, 49 patients was enrolled in the study. That is include T4 sympathicotomy in 77 hand, and T4 and T5 in 15 hand, T3 in 6 hand. That's the result. Hand temperature rose in 88.8% patients. No rose or drop in 11 hands. All patients were followed up except 3. In this table, I show in all patients the association between intraoperative hand temperature change and the curative effect. As it showed that in those unsatisfied hands, the Tmax were all less than 1 centimeter, but in those hands with Tmax less than 1 centigrade, 87.6% of patients were satisfied. In this group, more patients feel satisfied. Only around 12% patients feel unsatisfied. This table shows in T4 group the association between the intraoperative temperature change and the curative effect. In this, we can also say that in those unsatisfied hands, the Tmax were all less than 1 centigrade. But in those hands with Tmax less than 1 centigrade, 88.9% patients feel satisfied. So I think it is a negative result. Intraoperative temperature change of the hand may have certain correlation with the curative effect, but the predictive value of temperature change for curative effect is insufficient, I think. So this is a negative effect, and this negative result for the study expected. That is, how can we predict the results? Why some small proportion of patients feel not so satisfied? This is my further study, perhaps. Thank you all. This is my picture. This is my email address. I'm from Peking University People's Hospital. Thank you. Any question? Sorry.
All the patients in whom you have done these operations, all had severe hyperhidrosis, or others someone have mild or moderate also? Because the reason I wanted to know, even the mild, you have done this surgical procedure, or even all the patient had severe hydrosis?
The patient with simple hyperhidrosis, we perform the T4 with hand and axillary combined axillary. We use T4 and T5, and sometimes we designed to perform T4, but in operation we find that on the segment of T4, the vessel and the nerve is so close, so we have to perform the T3. Sometimes we designed to perform T4, but in the operation we have to perform T3. That is why some patients not perform the designed procedure.
And is all the patients being followed up for having this as a permanent solution, or someone had recurrence of the disease after having these operations? All these patients, have you had follow-up for the later months or years or something to know that if this operation was successful as a permanent solution or has a recurrence of this
I followed all the patients except three. Perhaps 5% of patients relapsed. 5%.
So in how many years, sir?
Long-term follow-up. Till now, in our single center, we have performed around 500 such procedure. Around 500. Traditionally, 10 days ago, we performed the traditional procedure. That is, resection, that is multiple site, multiple level, and so many compensatory sweating. But the effectiveness is always near 100%. The efficiency is always good. Till now, we perform T4, only 5% of patients feel not so satisfied. But the effect is long-lasting, is permanent, very, very permanent. Yeah.
Thank you, sir.